So before we begin our presentation on epilepsy treatments and Rett syndrome, I'd like to direct your attention to a precursor talk on an important related topic in Rett syndrome, seizures and Rett spells. So we know that people affected by Rett syndrome can have events that might look like a seizure and might be a movement disorder, might just be shakiness. We're not really sure. This recorded presentation from our Ascend 2024 summit this past summer in Colorado discusses Rett episodes versus spells, seizures, and movement disorders, both how to clarify the cause of these shaking episodes and current thoughts amongst our Rett Center medical directors about the best methods of initiating response to them. So we had many questions come in during registration for today's webinar on the topic of spells versus seizures. So I invite you to please watch this recording and reach out to me if you still have questions. But today's topic is epilepsy treatments in Rett syndrome with Dr. Robin Ryther. This webinar will expand on the information presented at Ascend 24 during Dr. Ryther's introduction to epilepsy in Rett syndrome session. Dr. Ryther is director of the Rett Spectrum Clinic at Washington University in St. Louis and St. Louis Children's Hospital Rett Spectrum Clinic. Robin is an associate professor of neurology and director of the Rett Spectrum Clinic. Born and raised in St. Louis area, she received her undergraduate degree from the University of Missouri, Columbia, before completing her MD and PhD at Vanderbilt University School of Medicine in Nashville, Tennessee. Following medical school, Dr. Ryther completed her pediatric and neurology residency at Massachusetts General Hospital as part of the Harvard Combined Program. While there, she developed an interest in epilepsy and returned to the St. Louis area to complete her neurophysiology and pediatric epilepsy fellowship at Washington University School of Medicine. She stayed at WashU School of Medicine as faculty in 2013 and worked to create the Rett Spectrum Clinic, which opened in 2015, almost 10 years ago. Dr. Ryther sees pediatric epilepsy patients in both children and adults with Rett spectrum disorders. We've invited you to this RettEd session for a focused discussion of medication options, but also non-medication options, including special diets, surgical options, and supplements such as CBD oil. Dr. Ryther will also review special circumstances specific to Rett syndrome to be considered. This information is appropriate for people of all ages with Rett syndrome. Thanks for submitting your questions in advance, and please submit additional questions that come up throughout the presentation, and we'll address these during the QA session at the conclusion of Dr. Ryther's presentation. So now I invite Dr. Ryther to take the stage and help us on our journey to better understand epilepsy treatment and Rett syndrome. Hi, Dr. Ryther.
Hi, thank you so much for inviting me. And good morning and good afternoon to everyone. We have quite a different set of time zones today. So I am going to go ahead and transition to our talk today. All right, perfect. All right. And so as a reminder, as Paige just talked about, we're actually going to begin today's talk just highlighting two of the topics that were presented in the first portion of this discussion at the Ascend conference. These are so fundamental to our basic understanding of seizures and epilepsy and Rett syndrome and the care of seizures and epilepsy and Rett syndrome that I felt important to kind of re-highlight those for today's discussion. From that, we're going to segue into treatment of acute seizures or seizure emergencies, followed by an approach to daily initial treatment, followed by what do we do when that doesn't work, and how do we approach drug-resistant epilepsy. There's a lot of sort of basic information that, as Paige said, I would encourage you to review that previous discussion, especially if you haven't had a chance to review this type of information before. And so I think the first and most fundamental question to ask is, well, how many patients with Rett syndrome even have epilepsy? And this is actually something that, depending on the type of literature you look at, has really widely divergent numbers, anywhere from the 40s all the way to the 90s. And so the fundamental answer is that we don't always have a perfect answer here. And the reason for that lies in the fact that, as every family already knows, Rett syndrome is complicated. And so I'd like to remind ourselves of the role of EEG in Rett syndrome. And to have this discussion, I want to train you all quickly on thinking about what do we look at when we look at an EEG. And so for any individual, we start by what we consider the background. And so without a MECP2 mutation, we're looking at things to be the same from the left to the right. We're looking for certain developmental features to appear by certain ages and to reach certain rhythms and certain patterns by certain developmental and age markers. Within Rett syndrome, however, when we look at the background, it can be normal initially, but we then expect to also see changes in this background rhythm with slower rhythms overall, occasionally lack of normal features, and some additional rhythms that are unique to Rett syndrome. The second thing that we look at when we review an EEG are things that we call sharp waves or spike waves. So these are the little pointy things that you can see on the left here. And in general, the analogy that I like to use is that if a seizure is a fire, these are like little sparks. And so outside of Rett syndrome, without MECP2 mutations, then from that perspective, we will often have, these little sparks as a clue that someone might have epilepsy. So in Rett syndrome, we can have a variety of different types of little sparks. We have focal spikes, which are areas of only one portion of the brain are affected, or generalized spikes, which are all over in the brain at one point in time. We also have a subcategory called multifocal spikes, which means that it's one area, but more than one area of the brain involved. And last but not least, when we look at EEGs, the third category of information we're looking at are actual seizures. And so from that perspective, again, that analogy that helps to link some of this information is that if a seizure is a fire, that we're looking for these little sparks as clues to whether or not someone might have epilepsy. And so when we think though specifically about EEGs and Rett syndrome, if we think without a MECP2 mutation, the clue that those sparks exist is a clue that there's also fires or there's also seizures around. But in Rett syndrome, you can have tons of little sparks, but never have a fire your entire life. And that's because fundamentally, all EEGs are abnormal by the age of 3 years old. And so what we really focus on instead of routine or shorter EEGs is we actually think instead about EEG video. This can be anywhere from a few hours to several days or even several weeks in special cases. And what our true focus is to capture on the spells themselves. And so trying to clarify what the funny movement or the funny moment that just happened actually was. These are sometimes complicated. We might need even more than one example. And the reason that this is so fundamentally important was really looked at very carefully by Dr. Glaze back in the late 1990s. And what he ended up doing was he studied over 80 patients who the vast majority of them had been previously declared by a physician to have seizures. And they had a series of spells or events that were then captured on EEG. And the bottom line is we were wrong most of the time. In fact, over 80% of the events previously declared as seizures were not. And so from that standpoint, well, everything that looks like a seizure is a seizure in Rett syndrome. So now as we segue to, well, how do we even begin to approach this? How do we approach the moment, the fear, the challenge of something happening right in front of our eyes? And so from that standpoint, you have to start by saying, well, does it even need to be treated at all? And there's a number of different things to think about with this. The first is, well, how often does it even happen? You know, if this is something that's only happened once in a lifetime, well, maybe we don't need to treat it. But if this is something that happens every year, but is very mild and doesn't have a lot of risk associated with it, well, maybe we don't need to treat that one either. But if this is something that's happening multiple times a day and may have a high risk of things like falls or injuries associated with it, well, that's a little bit of a different answer and is going to be much more likely to need to be treated. Even if it's not a very risky event, but it's interfering with normal functions of life, like communication, for example, well, that means it matters too, and it matters, and that's more important. And then last but not least, is there anything else driving these events that we can instead fix? So that instead of worrying about extra medicines, if we can, for example, fix constipation instead, that we might instead be able to make all of these go away, or at least to a reasonable level. And so regardless of how we approach it, you should always think of this as a very personalized decision with your Rett doctor. And keep in mind that just because it's the right answer today doesn't mean it's the right answer tomorrow or next week or 5 years from now. But ultimately, whatever you do, we always need to think about having a seizure emergency plan. And so how do we approach that initial part of the discussion? Well, the first is to have a plan at all. And so sometimes this is actually a written document like a seizure action plan for schools. But sometimes it may instead be simply talking about it as a family, to decide where and when we're going to have medication stored in the house. What will we do? Making sure that someone who cares for a loved one on a regular basis, like a babysitter or maybe a grandparent, is also aware of what's been going on and how you would want it approached. And then we think about times that seizures themselves may become a little bit more challenging or a higher risk. And the three most common times for that are seizure clusters, seizures associated with illness, and long seizures. And from that standpoint, when we think about seizure clusters, we often will talk about things that are repeated every few minutes over a period of time. It might be every minute or two for half an hour, or 5 hours, or an entire day. There's a medication in the United States that we use called clonazepam that is often frequently helpful in calming these things down. I always think of this medicine as your bad day medicine. We may not yet know what's driving the bad day, but something is making that day a little bit different than otherwise. It is important to think about how you're going to deliver the medicine. And so we generally prefer to use a version of the medicine called ODTs, or orally disintegrating tablets. Keep in mind, it may not be safe to swallow during an event, and so this helps it be absorbed in the cheek rather than something that requires active swallowing function. And of course, it's easy to still crush it and put it through things like a G-tube instead. This is also medicine that sometimes we give over a short burst of activity, especially when there's something else going on that we expect to end but is making life worse. Illness is a really good example of this. And so we often will design something we call a bridge to help calm things down for 5 days or 6 days until we're over our illness and that driving factor for what's making things worse goes away. And last but not least, the most significant emergency is often longer events that are lasting longer than 5 minutes. The reason most doctors use 5 minutes as this boundary to have initial and additional treatments created is because we know that seizures that last longer than 5 minutes are less likely to stop on their own without the help of a medicine. And the longer a seizure goes on, to hours and even days, the harder it is actually to treat based on changes in the brain that happen. So how we generally approach those in the United States is that we now have two main category of options. These are all still in the family of benzodiazepines, so they're still similar to the clonazepam that we talked about first, but they're available in a rectal option and two different nasal sprays. The option that's best for your family and your loved one is going to be personal. And so, for example, a younger child, a rectal medicine may be the better choice. But a teenager that's harder physically to move around and to have access to, maybe the nasal spray is the right choice. But keep in mind there are other challenges with nasal sprays. For example, if you have a lot of snot or congestion, then that might be something that affects the absorption of that medicine instead. So this is still a very personalized discussion, but know that these types of options are readily available and are things that, depending on what's going on in life, may be something you need to have on as an as needed basis for the future. In addition to potentially having medications around, we have to talk about, well, how do we help our loved ones through the actual seizure or the event itself? And what we would typically tell anyone is we talk about what we call the seizure recovery position. So please notice that this individual is on a flat surface and they are on their side. We do that for two reasons. One, it's very common to have either drooling or worsening drooling or vomit during an event, and we want that to be on that beautiful rug you have rather than back in their lungs. The second is this is actually the position that puts the tongue forward in the mouth and allows better breathing access and better access to oxygen. We do want to clear away anything that's dangerous or might then impede breathing. So for example, you can see there's nothing around the individual. And this is also a position that gives more ready access to the rectum if it's needed for those emergency medicines. Some people will tuck a hand to kind of help just cushion the head just a little bit. You might sometimes see a more flat pillow or a t-shirt maybe, or if you had a towel with you, things like that. You do want to be careful though that it's not so bulky that you're again impeding that airflow around them. But this is often a position though that doesn't really work very well for families that have loved ones who are in wheelchairs. And so when you think about that, you have to think about the event that's happening and what's happening to the body as part of it. So it may be safer, in fact, to not try and remove them from the wheelchair than to get into this position. But even if they're in a wheelchair, one way that you can help them is to help them access their airway a little bit better by doing what we call a chin thrust. So that little pointy spot that's right at the back of your jaw, and some of us it's a little more prominent than others, you can go ahead and put just 2 thumbs right behind either side and then push forward as if you're aiming for someone's chin. That actually pulls the tongue into a slightly different position and opens that airway just a little bit better. And is frankly probably a more realistic answer for the majority of our Rett patients. So now as we think about it, how do we then approach the decision about whether or not we are going to try an extra daily medication, and how do we kind of make that decision, and what are our initial options to think about? And so from that standpoint, we really have 3 main categories. We have medicines, we have special diets, and we have epilepsy surgeries. And so the mainstay of treatment for quite some time in general is medication. And although you can see we've had an explosion really of the options of medications we have, the worst news I'm going to tell you today is that none of these are a perfect answer that will solve epilepsy and seizures in every individual. What the good news is, though, is as we've gained more and more options, we generally have also gained medications that are better tolerated overall. And so as we think then about that first medicine, we often have to talk about a balance between the good and the bad sides of a medication choice. We often like to match our seizure type to our seizure medication type because we tend to have better seizure control if that seizure matches. And so as a brief reminder from the first talk, just like those sparks that we talked about being focal or in one portion of the brain, that's also true for seizures. So you can have focal seizures in one area versus generalized seizures. Well, medicines, again, come in those same 2 categories. Some medicines just fit different types of seizures a little bit better. And in some cases, there's something that may, in fact, be a side effect, but particularly in Rett syndrome, in fact, may be a bonus. They may be something that's beneficial. We balance this, of course, against side effects, the potential for things like drug-drug interactions, and unfortunately, a large part of our reality is often cost. This may still include other things like blood work monitoring and bone health, and the family's perspective of what they think of medications in general. And so I do want to pause and actually highlight bone health because it's really critical and vital as we think about the overall health of everyone with Rett syndrome. And so in Rett syndrome, bone health is an especially large challenge because there are a number of things that place them at higher risk of having an increased risk of fractures. And so one of them is the fact that, of course, we have a decrease in our vitamin D levels overall. And that's something, of course, that many of us will target by both monitoring this in blood work and also thinking about supplementation. And for many of our loved ones, even if they do walk, they may still walk less than other people, which means they get less of that weight-bearing exercise that leads to that bone density being built up in our teenage years. A lot of the extra movements and problems with stability also simply mean that they have a higher risk of injury itself. And if you have to end up on a seizure medicine, then seizure medicines are an independent factor that has an impact on bone health and vitamin D metabolism. But not all seizure medicines are the same. So they all have the potential to play this role, but it's much higher for some medicines like Depakote, for example, than others. So this is something that anytime a Rett patient, especially a Rett patient on seizure medicines who may not be ambulatory, this needs to be paid special attention to. So what medicines have been tried in Rett syndrome? Well, the answer is pretty much all of them. And so essentially, as soon as a new medication exists, we essentially have tried it to see if we can find what we all look for and hope for, which is that perfect answer. And unfortunately, as I said before, that doesn't exist. And so as we think then about medicines, I will point out that it's impossible for me to cover every medication that's available currently in the United States, and especially not worldwide. But I'm going to highlight a handful of medicines. And just as we've been talking about seizures and EEG findings being, again, generalized versus focal, the medicines also come in that same categories. And so I want, in general, for you to think about trying to match seizure type to medicine type. And so we also consider certain types of medicines starter medicines. And generally, you're a starter medicine if it's a medicine that's readily available. That usually means it's lower cost. A medicine that's in general well tolerated and generally helps most types of seizures overall. So as we think about these medicines, I'm going to highlight things that are true in most cases for everyone, but may have a special concerns in the Rett population. So one of the first generalized starter medications is a medicine called levetiracetam or Keppra. Now, they were pretty smart when they made this medicine because they made it in essentially every formulation and option that you can. So it comes as a variety of pills, liquid and IV. There's even now a sort of a film that dissolves in the mouth as well that you can get. It's also medicine that generally doesn't have a lot of interactions with other things because it's cleared through the kidneys, so you pee out this medicine. But the big significant issue and the big side effect with this medicine is behavior side effects. So in our younger kids, this often is appearing as aggression or anger. And in our teenagers, it often will also appear as depression or worsening anxiety. And we know that anxiety in particular can already be a substantial issue within Rett syndrome. And so from that standpoint, it's often true that although this is a starter medicine for many non-Rett patients, it's not a medicine that I at least like to use as my first option when I can avoid it. That being said, for those who do have behavior side effects, sometimes some vitamin supplementation can help substantially, and that is vitamin B6. And so if this has been an issue for you before, it's something to think about this type of supplementation to see that if it helps as well. And so again, it's a reasonable option to consider, but there are additional options as well. And another medication is a medicine called lamotrigine or Lamictal. This medicine does not have a liquid option available, but it does both have pills and a chewable form. And both the pills and the chewable form can be crushed and put in with a, either like 10 cc's or 10 milliliters of water or into things like applesauce or pudding to deliver an alternative way for people who can't swallow pills or can't necessarily chew them well. The main reason we don't often use this medicine is that although it's incredibly well tolerated, it is often a medicine that has a little bit of a slower start to it. And so it takes an average of 3 months to start this medication with once a week changes. And the main reason for that is if you go much faster than that, you can have a pretty significant rash that if left unchecked can end up being so severe that it acts actually like a burn. And so this is not a medicine that you can rush. And so if things have suddenly appeared out of nowhere and are substantial and a concern, this isn't a medicine that can probably be your first start because it's not a medicine that I can start quickly. The other thing to highlight is that it does have a substantial number of drug-drug interactions. So the body gets rid of it through the liver, and it uses enzyme systems that are often used for other medicines as well. And so in particular, a medicine that is more commonly used in Rett syndrome would be things like birth control, for example, and this medication often interacts with them as well. So where do I often start, but is not always necessarily the right answer for everyone? Well, it's a family of starter generalized medicines called Topamax and Zonegran or zonisamide and topiramate. And the reason we start this reason is because we are often looking for medications that, again, may have beneficial side effects as well. And of course, many of our young ones have pretty substantial breath holding, and this is also the treatment for breath holding. And so from that standpoint, often low doses of these medications can help calm breath holding if it needs to be treated. So if we have to be on a seizure medicine, it's nice to have bonus benefits as well. But they both have their own potential issues as well. In that first, it can be a little bit more challenging to deliver because it's not readily available as a liquid. In the United States, there has recently been a liquid that was made from this medication, but it's still considered very expensive and is not always approved by insurance. That being said, the capsules can typically be opened and put into things like water or a drink or a spoonful of things as well, or delivered through the G tube in that way. The biggest Rett specific concern that I have for both medicines is weight loss. So this medicine certainly decreases appetite. And so for someone who eats completely by mouth, this can be sometimes things that would stop them from eating at all. And so that is obviously not okay. And we know that an appropriate BMI of at least the 25th percentile is a goal for all of our Rett families, for our Rett loved ones. And so from that standpoint, we have to watch this very carefully. This is a little bit easier, of course, to manage if, for example, your loved one has a G tube, because we can help give them supplementation or add extra nutrition if we need to. The other thing I would point out between these two medications is that in general, I think of Zonegran as the medicine that is better tolerated, whereas Topamax has the same set of side effects. They just tend to be more significant, more stronger, and at lower doses do you first experience them. But the flip side is also true for seizures. And so from that standpoint, Zonegran is a bit of a weaker medicine for seizures, but Topamax is often a stronger medicine as well. So again, as we talk about this list of side effects, the main thing to keep in mind is that if you didn't tolerate Topamax, but it really helped your seizures, it may be something that's worthwhile to consider switching to the milder, gentler cousin of Zonegran. Now, most of the other things, again, are side effects that are potential, but generally not a substantial issue within Rett syndrome, with the exception of whether or not you just are too sleepy on it. One of the nice things that, again, may be another benefit in Zonegran is that it's a once-a-day medicine. And so we generally take it at night. And so often helping us sleep a little bit better is a way that we can also have a beneficial side effect. But of course, the goal is to be awake in your normal self during the daytime. And if that's not happening, then that's not okay either. So again, although this is not always the right answer for everyone, it's generally a reasonable place to begin for many Rett families. Switching then to the starter medications for focal seizures, or again, seizures that start in one spot before spreading outwards. Though traditional medicine in the United States for many years has been oxcarbazepine or trileptal. And so from that standpoint, this is available as tablets and liquid, but I will warn you right now, the liquid does not taste good at all. And so if at all possible, if you have a G-tube, that's the way you would want to deliver it. The real issue that we run into in anyone, but especially in our Rett families, is that this can be very sedating and make you very profoundly sleepy. If we are doping up your loved one, then that is not the right place to live and not something that we would want to continue. From a behavior standpoint in general, this tends to be well tolerated in older individuals, so teenagers and above. But in our younger individuals, they can often have more significant behavior problems that in many cases can actually be from fatigue. One of the good news from the United States, at least, is that we more recently have a newer medicine available called lacosamide or Vimpat. And part of the reason I say this is good news is it is also a really excellent focal seizure medication. But from that standpoint, it's much better tolerated than the trileptal we were just talking about. And only within about a year or so has it become fully generic. So this is the medicine that if I'm going to start for focal seizures that I would start with now, whereas even 5 years ago, an insurance company would sadly not have allowed me to. And so at low doses, it tends to be profoundly well tolerated. It also has tablet, liquid, and IV options easily and readily available. And only really at high doses do we have problems. And high doses are things that are reversible because you would lower the dose. So I make your child drunk. That means that's not a dose that's appropriate for them. So that's really where we think of our starter options. But I do want to highlight some of the stronger seizure medicines, in part because they have some very special challenges within Rett syndrome. And I want to make sure that you're aware of them so that you can recognize them because they tend to be just a little bit more unique. But the reason they often get tried is that as a seizure medication option, they're often a stronger medicine or may target seizure types that are traditionally a little bit more difficult to treat. So one of the more common ones in the United States that is also now recently available in an inexpensive format is clobazam or Onvi. So this is available as a pill. It's also available as a liquid. One challenge with the liquid is that this is a controlled medicine in the United States, which also means that they will not dispense any extra. The liquid is especially sticky, which means that it's a little bit challenging to get a full dose in the last couple of doses that are in every bottle. So if at all possible, we try and keep people on pills, which can be crushed and put through G-tubes because the liquid is just challenging to work with. But the challenge with this medicine is that although it's good at treating seizures, it's also a little bit of a muscle relaxation. And in many cases within Rett syndrome, we are either floppy throughout our whole body, or as we get older, we may still just be floppy in our core, meaning the areas that would control things like chewing and drooling and our gut and peeing and pooping. And so if we are too floppy because a medicine sort of pushes us up the wrong direction, then we can have problems with increased drooling, which also means that sometimes that drool can end up in our lung and we can have infections like aspiration pneumonia. And we've also had many Rett families who tell us that their children stop eating on it because their ability to coordinate the chewing and swallowing function becomes so difficult with just that little bit of muscle relaxation. It also can make constipation worse because when the gut relaxes even more, then the gut can become more constipated. And so that's also a significant challenge as well. And especially for our males, they can often sometimes struggle with a problem with peeing. And that's because there's a muscle that helps you pee that when it's too relaxed also can lead to urinary retention. Now, in addition to these types of challenges, if low doses are all you need to control your seizures, well, that may very well be tolerated from you. But in general, what a low dose is for Rett syndrome is far lower than it would be for someone without Rett syndrome. So you need to watch very carefully for these challenges if you try this medicine. It can also have some behavior issues, but it's far less than Keppra, as we were talking about earlier. One of our oldest medicines is a medicine called Depakote. And if you really look at numbers, this is probably the most commonly tried medication in Rett syndrome, in part just because it's been around for longer than my lifespan. It has a number of issues, including sleepiness and sedation. Mood is also a little bit unpredictable and tends to be somewhat age dependent. So again, younger kids have more struggles with mood than older kids do. And it has a profound impact on bone health, as we were mentioning before. Another very special Rett specific thing is that there's essentially a vitamin cofactor in the body called carnitine. And in Rett syndrome, you have what's called a secondary carnitine deficiency. And so we often will check for this to make sure that you don't need this additional vitamin supplement. Well, in the body's case with Depakote, it actually uses carnitine to get rid of Depakote. And so what that means is that you can end up even lower. And so this is something we frequently monitor in our Rett patients who are on Depakote. It's thankfully a fixable problem, though, because there tends to be a supplement that's fairly readily available that can help solve this problem. But if you're low on carnitine, the symptoms of being low on carnitine are being tired and moody, and nobody wants that. And so having that additional supplementation may be needed. There are some additional risk factors for this as well, which require a lot of blood work monitoring, which is not trivial for anyone. And theoretically, there's an increased risk of liver failure or bone marrow failure. Now, Rett syndrome itself does not make any of those particular risks higher, which is important to be aware of, but it still means that your loved one would have fairly routine and regular blood monitoring as long as they're on this medicine. On a bright side, one of the good things is it does increase appetite. And so sometimes it can help our Rett patients encourage them to eat just a little bit more if it's safe for them to eat by mouth. But for those who are on a G-tube or maybe on a specialized diet, if it's not safe for them to eat by mouth, this can sometimes lead to agitation because they're hungry or hangry, as the word may be. The next option I wanted to make, again, families aware of is a medicine called felbamate or felbutol. And one of the things that's nice about this medication is it's what we call activating. So one of the common things you've heard me say about many medicines is it makes you tired or sleepy or dopey. And we don't want that for anyone. Well, this is one of the few medicines that doesn't do that. But it unfortunately has some pretty significant issues when it comes to Rett syndrome. It can have, again, a profound decrease in appetite, which if you eat by mouth may mean that you're not able to keep up your appropriate nutrition. And what is especially challenging, of course, in Rett syndrome is sleep at all. And this is a few medicines that when it wakes you up, it may in fact wake you up too much. And so that has to be monitored very carefully. And then just like Depakote, it can also lead to problems with liver failure or bone marrow failure. And so all of the same blood work needs to be monitored very carefully. So usually if you're on these medicines, you have already passed a number of those starter options and are working towards more significant seizure control. I did want to introduce a newer medication option that's really only been around, at least in the United States, for the last several years. And part of the reason I did want to highlight this is in both Rett and not Rett patients, this is a medication that in many cases is leading to substantial improvement in seizures in patients that have had lifelong struggles. And so from that standpoint, I think it's worth being aware of if you happen to be in that circumstance and have not yet considered trying this. It does have some challenges with it. So it is only available as a pill. It recently has been updated to do what we've all been doing already, which is to allow it to be crushed or to put through a G-tube. And especially it tends to target focal seizures the best, although it's reasonable to consider in some other seizure types as well. One of the bigger challenges we had initially is that the tablet sizes were often too large or required too big of a jump between different types of medications dosing. But they've recently introduced some smaller tablet size that has made that a lot easier. And now that we're allowed to crush it, that also means we can split it if we have to. And so some of those practical issues have thankfully gotten better. And unlike many other newer seizure medicines, it doesn't have any life-threatening side effects. And so from that standpoint, one of the risks is just that it is simply new. And so I can't tell you the 30-year history on it because that doesn't exist. But I certainly don't have to tell you anything right now about liver failure or things like that as well. And then something that is both a blessing and a curse for this medicine is that it has what we call a very long half-life. So a half-life is how quickly your body gets rid of a medicine. And this is an extremely slow process. Now, one of the good things about that is that means that you can dose it once a day, and we tend to dose it at night. But this life is so slow that even if you were to stop the medicine, your body would still test positive for it days later. So if we end up making you on too high of a dose or you're too sedated, then from that standpoint, it will take a little bit of time to fix it. The other thing just to be aware of, because if you're on this medicine, again, you've probably tried multiple options at this point, is it can have a lot of drug-drug interactions. And in particular, clobazam or Onbi, it has a very strong interaction with that needs to be accounted for. And so from that standpoint, the other biggest practical issue with it is it just is an extremely, unfortunately, expensive medicine. And in general, insurance companies require a lot of paperwork to access this option. But we've had some good returns, although it is still not the final answer for everyone. And so I do want to stop and talk a little bit about CBD oil and Rett syndrome in particular, but to remind all of ourselves of a couple of quick facts. The first is that this is not medical marijuana, and even every different source of options for that is not the same as well. So marijuana has two main components to it. It has CBD oil, which is what we're going to spend our time talking about, and then it also has THC, which is the part that actually makes you high and is apparently also the part that gives you the munchies. And so from that standpoint, there is a lot of data that THC can potentially make seizures worse. So when we talk about using marijuana, we're really talking about using CBD oil that's been purified, or at least as purified as possible. And that's where it's important to be aware that, for example, accessing it from places like Charlotte's Web in Colorado versus Bed Bath & Beyond or your gas station down the street is something that can be profoundly challenging and different because it's not necessarily going to have the same amount of purification, the same dosing, the same percent, and it's not necessarily going to be reliable from one bottle to the next, even if you're buying the exact same brand from the exact same location. All that being said, for some types of seizures and some types of epilepsy, it can be very helpful. It doesn't seem to be the miracle answer in Rett syndrome, unfortunately, but there are other genetic diseases like Dravet syndrome where it does seem to help a substantial number of patients, and in some cases in miraculous ways. It does have its own set of side effects. So from my perspective, it's a drug like any other. And so those side effects can include weight loss or a decrease in appetite. It can be somewhat sedating. In many cases, mood changes are for the benefit, but there are times that it can lead to irritability as well. And it can cause diarrhea, which is an important note, especially for those in the United States who might be on other medication options like trofinetide, where this is a struggle as well. And very rarely, it can also lead to problems with the liver, even if it's the only medication being taken. And so we do generally recommend liver monitoring while you're also on sources of CBD as well. It is also important to be aware of, though, that even if it's not necessarily the perfect answer for all seizure types, it can have other non-epilepsy related benefits, particularly in Rett syndrome. And although this is not yet well established through clinical trials, we have seen benefits, especially in dystonia, monitoring in sleep, especially sleep onset and sleep maintenance for some individuals, and in some cases for mood, in particular that anxiety. So there may be other reasons to consider low-dose CBD as part of your overall picture. I do want to highlight a specific medication known as Epidiolex, and part of the reason that, if possible, my preference is to help my families obtain this is because it's pharmaceutical grade. So at least that question mark of what's in this bottle versus the next bottle is gone because we have at least a reliable amount of purification and dosing information from one bottle to the next. Unfortunately, it's not approved specifically for Rett syndrome. And so it is approved for some genetic disorders, including Dravet syndrome and some types of epilepsy called Lennox-Gastaut. But it can also, in many cases, be accessed under an access program through drug-resistant epilepsy. And so this will require insurance paperwork and approval in the United States. And of course, every state also has different laws that are occasionally interfering or challenging for people who would like to try CBD oil. And so this is where we would often begin a lot of our initial discussions, but I want to talk about what it means then if this doesn't work and we end up with what we call drug-resistant epilepsy, and what are some other non-medication options to approach for the treatment of epilepsy and Rett syndrome. And so from the standpoint of whether medicines work or not, the answer is sometimes. The one trend that we have is the younger you are when your seizures start, you're a little bit more likely to have hard to control seizures or epilepsy, but that's not necessarily true for everyone, and there's never a perfect answer for all. So drug-resistant epilepsy is defined as 2 or more appropriate medications that have been failed due to ongoing seizures at maximum doses. You'll notice I did not say that you failed it because you had side effects. Unfortunately, that may be, in fact, the larger challenge or the bigger challenge is to find a medicine that you tolerate well and that you can feel your normal self on. But from the standpoint of this definition, it's not actually what we mean. We mean seizures are still happening. And so, as we think about this, we always should stop and say, well, are we truly maximizing our seizure control? And how can we do that to make, again, to get the best benefit from hopefully the lowest dose of the least number of medicines? And so the first is, are you even taking them? And if we're taking them, are we taking them at the right times of days? So your doctor will guide you on how often the medication should be taken. But for example, sometimes families may have struggles in the morning with their morning routine and may try to take a twice a day medicine after school. Well, that probably means that there's hours of the day that your loved one would then be more vulnerable to seizures because that's not the timing that's typically meant. There are often many triggers within Rett syndrome as well, and helping to manage those triggers or in a perfect world to even avoid them is also incredibly important. And one that's a little bit more unique to Rett syndrome is the gut. And so we all know that the gut can be a significant challenge, but constipation and anything that causes pain and discomfort in the gut in particular, for someone who has seizures in Rett syndrome, can absolutely trigger them in the moment. So as you have a breakthrough seizure, pausing and saying, well, is there anything else going on that I need to address or fix is really important. Sleep is also incredibly important, not just for anyone with Rett syndrome, but for Rett patients who have epilepsy. And looking for things like obstructive sleep apnea and directly treating those can also help seizure control. In some cases, that's the only final fix that's needed, is to help someone get to sleep better, to help then in conjunction with low dose of a medicine to improve their seizure control. Illness is also, unfortunately, a time period that patients with epilepsy often will have more significant seizures. And unfortunately, some viruses, COVID included, for example, can have a more tendency to provoke seizures. Fever itself is also a profound, significant trigger for seizures in those who have them. I added debut and trofinetide to the list here as well, to mainly make sure that I knew that in general, that we think of this medication as seizure neutral, meaning it neither really seems to help seizures or epilepsy, nor does it otherwise seem to make it worse. However, there's a but. And the but is simply this, that if the gut is so upset from the side effects of trofinetide that we have in fact seen families have worsening seizures in that setting, and that again, stabilizing the gut and treating the gut is really the most important part of moving past that. The other thing that's incredibly profoundly important to both be aware of for our young women who've entered their puberty years is that hormones can have an absolute impact on seizure control. And so for our young women in general, estrogen is the bad hormone, or the hormone that can activate seizures, and progesterone is the good hormone that not only can suppress the estrogen or the bad one itself, but can independently help treat seizures as well. And so if you have a period and epilepsy, we generally would ask all of those families to track both their seizures and their periods on a calendar together, to allow your doctor then to look for the patterns that suggest that this may be a component of things that are part of your seizure control. So there may, of course, be reasons to think about either limiting or regulating your periods and menses. And so if you're thinking about that anyway, and you're looking at options for someone who has epilepsy, then you may want to consider the type of hormones you're using. So for example, a low dose progesterone only pill may be a better solution than a pill that contains estrogen as well. So you might as well, again, improve seizure control at the same time. For patients who do have these clear patterns, if they also have regular menses, sometimes we will use additional medications for short bursts at the correct times when they have breakthrough seizures. And so, for example, that clonazepam or clonazepam that we talked about earlier as a bridge during illness can often be a bridge during our periods if that's the right time for your loved one to have breakthrough seizures. So what do we do though when meds and hormones and doing as much as we can to regulate the diet is still not enough? Well, I would always ask every family to pause and make sure that we're dealing with seizures. So as we talked about before, we're wrong a lot of the time. And so whenever possible, having confirmation on EEG video is very helpful. In addition to confirming the diagnosis, it also can guide you as to what type of seizure it is, which can then again help you match the right medicine to the right seizure type. Then keep in mind that it's not about just controlling seizures, it's about maximizing life. And so we're really looking for that balance. And then we think about things like dietary and surgical options. So, as we think about dietary options for epilepsy, in the United States and around the world, we use something called the ketogenic diet. Now, I'm always careful to warn families that there is a weight loss option for ketogenic diet that you might be more familiar with. It is not the same thing. It has the same concepts, but the dosing or the level is really extremely different. So in the United States, we have a diet that's mostly made up of carbohydrates, and then we have some protein and frankly, a lot of fat. So what the ketogenic diet does is it switches us from a diet that uses carbs as our main source of fuel to using fat as our main source of fuel. So it has little to no carbohydrates, an appropriate amount of protein for growth and nutrition, and then the rest of the diet is almost all fat. What this does is it switches our bodies from using glucose or things that come from sugar as its energy source to using ketone bodies, which help in the brain. We actually don't fully completely understand why the ketogenic diet works to help control seizures, but once someone enters that drug-resistant pathway, it can be an equally valid improvement for seizure control as anyone else, as any medicine. There are other options for diet that I think of as sort of lower treatment options or the lower doses, things like modified Atkins and low glycemic index treatment as well. And I know we're running short on time, so I will try to be less wordy. And so from that standpoint, when we think about ketogenic diet and Rett syndrome in particular, the bottom line is it can work just as well as it can in anyone without Rett syndrome who has epilepsy. It's definitely a little bit easier to do with a G-tube, and the side effects to be aware of are constipation, impacts on bone health, growth, and cholesterol. The other thing to know is that certain medicines don't mix well because of the tendency towards acidosis. So that Zonegran Topamax I spent a little bit of time talking about is not a great option in Rett syndrome. Excuse me, on ketogenic diet at the same time. In terms of surgery, we have palliative options that look at mainly neurostimulation or VNS, RNS, and DBS, or the corpus callosotomy. So in terms of VNS, this is something that looks kind of like about the size of a pacemaker. It's implanted in the chest wall, and it has a wire that connects to the 10th cranial nerve or the vagus nerve. Within Rett syndrome, they have looked at using this in a small number of patients, although it's frankly been used a lot more than it's just in trials. And the results are similar, that they have about a 50% reduction in 50% of patients. So it helps seizures, but it doesn't tend to stop them. And what was noted, which was interesting, is that they can have a profound improvement in overall alertness as well, which was interesting. It's not a reason to place it, but it's something that could be a benefit. The thing to be aware of that's special to Rett syndrome is that it can worsen obstructive sleep apnea, and given that's at a higher rate in Rett syndrome to begin with, it's something to be aware of. Deep brain stimulation is just a little bit more modern in terms of its timing. You might be more familiar with it as a treatment for movement disorders and things like Parkinson's, but it's really only been looked at in epilepsy for the last 10 years. It has that same sort of computer and battery pack that goes in the chest wall, but now it connects to the brain itself and to deep portions of the brain where we target different areas where seizure regulation and control can come from. This does require surgery, in fact, 2 different steps of surgeries, where first the leads themselves are placed into the brain, and the second is where the generator itself is also placed. And generally is well tolerated, and is certainly something that could be considered for epilepsy. There really isn't, unfortunately, a lot of data within Rett syndrome, at least not yet, but I do think there are some intriguing concepts, especially for our young ones who have movement disorders that may benefit from DBS as well, as to whether or not different electrodes could be used to target both epilepsy and movement disorders at the same time. So that's to come in the future, we hope. Corpus callosotomy is a cut of the bridge between the front 2 portions of the brain called the corpus callosum. You can either cut this bridge completely or you can cut just a portion of the bridge. And in those individuals, it has an improvement in seizure control from about 1/2 to 2/3. And in general, we think of this as working for people who have tonic seizures or generalized seizures, and especially for people who might fall with their seizures or have drop attacks. What is newer and is incredibly helpful because it's a much less invasive and better recovery time period is that most centers can now offer an option where lasers are used rather than a more significant operation. So again, there's not a lot of literature on this in Rett syndrome itself, but it has been used for appropriate seizure types in some handful of Rett seizure patients and helped with them in either minimizing or reducing their drop attacks, which can be a very significant safety risk. So the bottom line take-home seizure message is first, make sure it's a seizure. So we will never treat it successfully with seizure medicines if it's not seizures. Second, in general, a slow and steady approach, starting low, going slow with medicines tends to be a more beneficial approach in Rett syndrome. Make sure you're thinking whole body and whole picture. A doped up kid is not anything more than a doped up kid, whether they're still having seizures or not. And we still need to continue to research this. In our first talk, we didn't get into this today, there's not a lot of absolute data that says that a certain specific mutation is going to be the information that gives us our final answers either. And this should really be a partnership between you and your doctor. And ultimately, don't forget that whatever you decide today is not the final answer if something new comes up or there's more information tomorrow. And so again, not all seizures and spells in Rett syndrome need a daily medicine or need to be treated. But at the same time, don't forget that just because you have Rett syndrome doesn't mean we have to accept recurring seizures that are life impairing and are a significant safety risk. I'd like to thank the team here, especially my partner in crime, Dr. Judy Weisenberg, and of course, all of our families and patients who inspire us every day. This is from our recent strollathon, which we were thrilled to be joining everyone at. And I'm incredibly grateful for the support of the International Rett Syndrome Foundation and for inviting me today. And then I would just like to advertise a talk as well. And so there's a website there at the bottom. But in our yearly education day will be coming up this April. There is a virtual option for those of you who are long distance. And the topics that we'll be talking about this year are womanhood and Rett syndrome with Jane Lane and different types of equipment options as well. And then, of course, as was mentioned by Paige earlier, we are celebrating our 10th birthday coming up soon. And so we'll be celebrating a little bit during that time as well. So Paige, I'm going to stop sharing now to allow hopefully some time for questions.
Great. Thanks, Dr. Ryther. Oh my gosh, I could just listen to you all day long. You give such practical advice rooted in experience, and I just want to thank you for sharing all of your information today. We have quite a few questions in the queue. I think we'll go until about 5 minutes after the hour, if that's okay. And if we have questions left that we haven't answered, I can take them offline with Dr. Ryther and get back to folks individually. Some of the questions are very specific to an individual, so I am going to hold those questions for if we have time or to take offline. If I can, let me share some that are in the queue. I think you might be able to look at the QA, but let me share some that might be general points that I think you touched on in your presentation, but worth a revisit, which is, again, if they're having trouble, maybe multiple attempts at capturing an episode on an EEG, have tried medicating, seizure has not been, the episode has not been caught in a hospital on a video EEG. Some medications have been tried, others have been stayed on board for years with add-ons, adding, and we're not seeing a change. What do we do?
Yeah. So this is a tough one. And that's basically the family that's in the position none of us want to be in. And so the first is to always pause. And sometimes the greatest thing I do for any family is taking away medicines. And so sometimes doctors get nervous to do that. Families get nervous to do that because there's a reason we were on them. But especially if life is essentially the same and the medicine didn't fundamentally make a difference, either for better or for worse, then getting rid of it may actually find benefits that you didn't even realize were there. But having a fresh set of eyes, a fresh look at everything is often incredibly helpful. And start making sure that you're journaling. My families are the ones who come up with the best triggers, the best understanding of their loved ones. And, finding out whether or not there's a pattern, maybe a clue then to something we can fix or we can solve. And so from that standpoint, that's an incredible thing to look for as well. And then although you may have tried hard, there are sometimes some creative tricks that don't sound exactly right in the best of all worlds to how you might make that EEG experience also go better. So for example, if you make your loved one a little extra constipated that week, which is not normally what any of us want to do, you may actually trigger the events more likely. So I don't usually do that in patients without Rett syndrome, but when we're on our second or third attempt and we have the time set aside and we think this is the right moment and we think the data is needed, then we often will try that. And then otherwise, just again, stepping back and saying, what is really life about? How is this impairing my loved one's life? What is the true safety risk? And how do we reach that better balance?
Great, thank you. So really is work very closely with your epileptologist. And what I didn't hear you mention, so let me just insert this question. A general neurologist versus epileptologist.
Versus Rett doctor. So,
Yeah,
so all general neurologists are trained to some extent to treat seizures and epilepsy. But what an epileptologist is someone who has dedicated additional time in their life and training to treat and learn about the higher level of seizures and seizure medication options and things like the surgical options that we reviewed. And so what's even better is an epileptologist who's also a Rett specialist as well. And the reason I say that is because frankly, Rett patients break the rules all the time, as we all know. And so having a different understanding of how you approach epilepsy and Rett syndrome is really fundamentally different than epilepsy in the rest of the world and the rest of our populations. And so in the best of all circumstances, there's, half a dozen of us in the United States that really focus on both of those aspects. But even a Rett doctor working closely with your epileptologist or seizure specialist at your institution also can be helpful to really maximize that discussion back and forth so that they don't forget things like constipation may be part of the problem, or that, yes, they have Rett syndrome, but hormones still may play a role, and don't ignore that aspect either. So at the end of the day, if you have drug resistant epilepsy, I would hope everyone would at least be seeing an epileptologist, if not a Rett epileptologist.
thank you. So that's a great comment on a strategy. So I love that you mentioned for parents to journal. So sometimes the patterns that you may not be seeing can be detected. My Rett Ally is a great tool for you to be able to journal that along with the constipation, along with other hormonal cycles, along with sleep, so that you can reveal some of these trends and then advance your care. So if you're a general neurologist, is maybe you're getting into places where you're asking the questions of what medication, what dosage, not catching it on EEG. Your recommendation I'm hearing is to advance to an epileptologist specifically, and if possible, get your child into a center of excellence, such as WashU, to really work with a Rettologist who is an
Absolutely.
epileptologist. Great, great advice, because things are pretty unique in Rett syndrome at times, and it gets to be a complicated neurology picture. Got a couple other questions about specific medications that you mentioned. A few questions about dosing,
Mm.
specifically about Xcopri and um, uh, I know you're not going to get into it, but the specific ones that were asked were Xcopri, Vimpat, and Keppra. How do you know where to start with a dose and where to go?
Yeah. So in general, every seizure medicine has a dosing range. Okay. And so that range is based on age and body weight. And one thing to keep in mind is that although your Rett loved one may be an adult, they may be beneficial to base it still based on body weight, given that many of our young adults are still on the lower end of an adult weight. And so, from that standpoint, in general, you want to start by just getting to the lowest therapeutic range possible. There are some medicines that may have a blood level that guides the doctor, but most do not. And so, from that standpoint, you need to think about pausing there and then seeing what happens from a side effect standpoint, a tolerance standpoint, and then a seizure or spell standpoint. And so, one of the other keys for Rett in particular is we find that we sometimes need lower doses from a tolerance standpoint than other individuals might, and that going slower makes more sense. And so, we often may do a once a week change. Well, sometimes in Rett, it's a once every 2 week change because the side effects aren't always as apparent that first week that come out that second week. And so you're looking for the balance point, or you're looking for either the theoretical end based on body weight or the stop time period they stop tolerating it. Because again, I don't care if you reach the max dose, if you're asleep all day long, that's not a life to live. And so from that standpoint, you have to work that way. Now, that timing, and just because you mentioned Xcopri in particular, I do want to point out it's really important for Xcopri to be super slow. And so again, standardly we would go up every week for many medicines. That's an every 2 week. And again, in many cases, we have pause points when we go up on that medication to be very, very slow about. And that's why to me, I was thrilled when they introduced the lower pill sizes, because that let me access patients that I couldn't access before, because insurance doesn't always do nice things to us. And they would use excuses like, well, she can't cut a pill in half because it's against the rules, so you don't get the medicine anymore. And now that we have some of those lower pill sizes, we can grind it up, we can cut it, we can fine tune and tailor things to patients that I couldn't even a year ago with that medicine. So that was really good news. So.
Thank you. I'll say my daughter's one of those complicated seizure kids, and she was first line to be getting Xcopri, and we've experienced all those things. And hopefully she's contributed to the ability to crush and go through G-tube, because we do, and different tablet sizes, and she's had great success on it. So I'm glad you brought it up. There was a question though, if you could hit again about crushing medications through G-tubes,
Yeah.
pills and disintegrating tablets specifically.
Yeah, it's a great question. So first of all, I cannot answer it for all medicines because every medicine actually has its own answer. So it's important to ask your doctor that question. Second, be aware that every time you crush a medicine, depending on how you approach it, you're going to lose a small percentage of it. And so whether you're losing 5%, 10%, that should be part of the equation as you think about that medicine. Some medicines are designed to be crushed or designed to have that be a safe route of application. Some medicines are not. And so some medicines have special coatings on the outside that will alter how the medicine's metabolized, and that's going to change what you do for it. It may still be a creative way to approach it, but it may change, for example, the number of times a day that you do it. I'll give you a perfect example is Depakote. So Depakote has a liquid available. It has something we call a sprinkle, which is literally designed to open and sprinkle into food. And it has pills, both what we call delayed release and extended release, which have those special coatings. Well, I can tell you right now, we struggle with the liquid a lot because it tends to settle out in the bottle, which alters the dosing from the top of the bottle to the bottom of the bottle. And you can imagine in epilepsy, that's a real challenge. So I prefer to never use it whenever possible. And so what we do, though, if we can't swallow a pill, is we use those sprinkles. Well, they don't taste that great. So a lot of kids refuse them, and they also clog up a G-tube. So they don't go through G-tubes very well. So what we do is instead we take that delayed release that I just told you can't crush. We crush it anyway, but now we give it more times a day, more often than we do if we're on twice daily. So these nuances are things to talk about with your doctor. That's a little bit more of a unique circumstances, but it kind of demonstrates all of the different possibilities, which is why I thought it was a helpful example. For many medicines, if a medicine is made as a liquid and it's easy to use, then that's often the easiest choice when it's reasonable for your family. But it still can be a struggle at times going through airports and packing things that might have to be in a refrigerator. And so it's not trivial. And so as you think through these practical everyday moments of life, make sure you're thinking about it and talking with your doctor, because I feel like sometimes that's things we don't do as good of a job with at actually bringing up and asking, how is this working in your life? So
Thank you. Yeah, it's complicated, and these medications are pretty intense. So you want to be very clear on working with your neurologist, epileptologist, pharmacist can also be a great consult on how to do
I
compliance.
will say one thing though, be a little bit cautious about changing anything you do based on what your Walmart, Walgreens, CVS pharmacist tells you. In part because your doctor may be more familiar with the latest advances in that medicine, such as the crushing Xcopri, than your pharmacist will. Or to put it differently, until a few months ago, they would have told you that's a bad no-no and not to do it. And so don't stop that medicine or alter what you're doing until you talk to your doctor.
Thank you. I think we have 2 more questions, and then we have quite a few in the queue, so we will take some offline. But there are 2 that I think are worth hitting. One pretty serious topic, but it comes up frequently in our community, is the incidence of SUDEP, or sudden unexpected death, for epilepsy. Can you address that, please, in Rett syndrome and what we know?
Yeah, so this is a really tough topic, and I'm actually going to broaden it just a little bit even further and talk for a moment about why do our loved ones pass away from Rett syndrome. And part of that is because we don't always know what the mechanisms are as to what happened. And so, in general, there are three main categories. One is just infection. So, we know that the everyday flu that might be not so bad for you and I can be deadly for a patient with Rett syndrome. That's also something that can make your seizures worse. So, it can make you have seizures that don't stop. And that can be something that can be deadly within Rett syndrome. We may, of course, already know about things like prolonged QT intervals, and that's why your Rett doctors do things like monitor their heart, because that can lead to sudden unexplained death as well. And for patients who do have epilepsy, but not for those who don't, there is something called SUDEP, which stands for sudden unexplained death in epilepsy. And this is a hard topic because I can't tell you how to prevent it. I can't tell you what the magic answer is. And none of us ever want to see this or hear about it. And unfortunately, I have also lost some families and loved ones to this as well. And so, from that standpoint, here's what we do know: it is a risk factor for anyone with epilepsy. I've been asked this on multiple occasions, so I'm going to state it out loud. An abnormal EEG without seizures does not place you at risk for SUDEP. Okay. And there are certain seizure types that are higher risk. So, for example, patients who have whole body shaking seizures are patients who have a little bit of a higher risk for that as well. Patients who also have seizures during sleep, especially unobserved sleep, are patients who also are considered at slight higher risk. So the numbers are higher than they would be for someone without Rett syndrome or someone even with Rett syndrome without epilepsy, but they still are small overall. There are also unfortunately no specific monitoring device that is the magic answer. As soon as we find one, we will absolutely have it in every room on the planet. But so you have to think very thoughtfully about, is this monitoring device going to even work for your family? Will it even detect their seizure type? Not all of them detect all seizure types. And decide what is better or not better than simply the old-fashioned baby monitor. So I didn't talk about this today, although I think I mentioned it in part one, is that we generally recommend for anyone with epilepsy, including Rett syndrome, that we have, a baby monitor with sound and video to help someone clue in or hear more readily signs that a seizure might be happening. And we know that some level of monitoring and living with other loved ones can help reduce that risk as well. And so taking your medicines on time and taking them every day also reduces risk. But beyond that, we don't have any, unfortunately, perfect answers. So it's a very tough thing. And it's what every family thinks about, whether they're really and bravely ready to ask it or not.
Thank you. It is a tough thing, but it is a fear that we all have. And so improving our ability to monitor these events at home and report them and share them with our personal physicians is the best recommendation that you can give. So thank you very much for talking about nighttime monitoring, because I think that is where a lot of fear and anxiety happens for us caregivers. In closing, I want to touch on two different topics. One is for the youngest of our loved ones with Rett syndrome, to again clarify value of getting a baseline EEG, understanding and advocating for that to happen, even though you said that early age, everyone's EEG is going to be abnormal. Do we get a baseline? And they're starting to wake up and have that startle reflex. When do we start worrying about whether that's a seizure or not? And I know that's in your movement webinar, but if you could touch on that. And then the last question I'd like to close with, if I can, so tee these two up, is management for school programs and how to write that seizure action plan for schools.
Yeah, great. So from the standpoint of routine EEG monitoring, we generally do not recommend it. And so from that standpoint, if your loved one is not having some new funny spell or doing something unusual or different, that's not something that's on the Rett to-do list. You have a long enough list already. It is not uncommon for them to have been obtained, sometimes even before a diagnosis of Rett has been obtained. or for a non-Rett doctor to obtain one, thinking that it's part of normal Rett care. Again, sometimes to move to a video EEG to try and clarify additional events, you have to have one just for insurance. So there may be practical considerations for that as well. But the data about the changes on the Rett EEG aren't data that tell us anything. They don't predict if your loved one will have epilepsy or seizures, and they don't tell us if that seizure or epilepsy was, the event that just happened was a seizure. And so that's why it's not something we make as part of our routine standard. Most schools in the United States will request paperwork of some sort. There is a standard Epilepsy Foundation website page. It is for anyone with epilepsy, not for a Rett patient with epilepsy. So there may be some nuances to that need to be edited or overwritten by your doctor to make it more particular for a Rett patient. But the biggest thing that I do and think is important for schools is to help define for them what we're concerned about and not concerned about. And so that's really where, again, a lot of very well-meaning teachers and paraprofessionals and school nurses get very alarmed by things that look very similar to seizures but aren't. Breath holding in particular is something that can be very alarming to them and may look to them like seizure activity. And so helping to educate them and define for them in the individual what spells to track, what spells to worry about, and what spells are seizures and therefore should be acted upon in a certain way is really important and doesn't always fit well into that form. And so sometimes we have more extensive letters that we include. And when possible, sometimes we'll even have families do certain video clips to that help. And they can take that video clip to do education with their school as well. Nothing will ever be perfect, but usually I also would advise in general that families know their kids best, not the school nurse and not the paraprofessional. And if something out of the blue happened that really doesn't fit what you've used to hearing or seeing, doesn't mean you don't report it to your doctor or to take notes on it, but it's really helpful to really think through that. The other thing is to, whenever possible, when something does happen, is to try and get direct information from the person who saw it. Unfortunately, what does happen at schools is a lot of telephone game, right? So it was witnessed by the aide over lunch who told the teacher, who told the school nurse, who then told mom or dad, who then told the doctor. Well, by the time we get to the doctor, usually some of the details that might be critical for understanding what happened are gone. So, so yes, there's paperwork, but that paperwork needs to be personalized and really sort of what needs to be sorted through as much as possible. So.
Thank you. That's very, very helpful information. So I appreciate you talking about very early on in life, what to do to identify and seizures or movement, and how to manage when our children are at home and outside of the home at school, and also what to do when if seizures become epilepsy, become difficult to control epilepsy, how to consider staying on drugs, coming off of drugs in the weaning process, and trying different drugs. And I really appreciate your in-depth evaluation of different drugs that are on the market and most commonly available in the US, and that there are emerging treatments that are non-pharmaceutical that could come into play. This is all incredibly valuable, important information, Dr. Ryther, and I know we're going to have future webinars in 2025 to go even more in depth on different avenues of neurologic impact with Rett syndrome and epilepsy and seizures specifically. We have a lot of questions in the queue that were written in about how to identify and treat a seizure, or a seizure every couple of years versus what is epilepsy. So I encourage everyone to look on our YouTube channel. We will be posting the recording of this session onto our YouTube channel in the next few days, and you can go back and revisit a lot of the very specific topics that you asked about in the queue, because you may have missed some of that discussion. The ones that are in our queue, Dr. Ryther, that are very child specific, if you don't mind, we'll take those offline in the interest of time and see if we can get some help for these families, because this is
Sounds good.
Yeah.
And Paige, I do want to say one thing about sort of the other topics, so to speak. So again, there's a lot of very good introductory information there, but I want to make sure, and there's a point made there that I want to make sure we also make today. Just because at the end of the day, we find out that it's not a seizure, it doesn't necessarily mean it doesn't still need treatment or help. And so again, a Rett spell or a breath holding problem or a movement disorder or whatever we think that is that other event when it's not a seizure may still need treatment, may still need help. And so keep that in mind that just because you've crossed seizures off the list and it gives you a different direction to go for that treatment doesn't mean you don't need it.
Thank you. That's incredibly important. And the fact that other things going on with our loved ones with Rett syndrome could be confounding the
Mhm.
incidence of seizures. So getting at all of the other things, movement disorders, sleep, breathing, constipation, all of those things need to be evaluated in the full picture of what are we treating and why are we treating it. That I think is an incredibly strong takeaway message. And a persuasive reason for families to visit you at your center of excellence in WashU if they live near you, or another one of the centers of excellence in our network if they live elsewhere in the country. And I want to thank all of our international attendees for attending as well. And we hope that you found a lot of value in today's presentation. So Dr. Ryther, thank you so much. We appreciate you and appreciate your work, and we look forward to inviting you back again for future webinars. Thank you for all that you and your area have been doing during October Rett Syndrome Awareness Month. Congratulations on your 10-year anniversary. We'll see you in April. And for those of us who can't attend in person, thank you for sharing the link to attend virtually. For all of our attendees, I want to thank you for tuning in today. I hope you got some answers to your questions or gave you different questions to ask next time that you're with your specialist and are talking about the care of your loved one. And remember to please stay replenished in your lives. You're doing a great job with your children by being here today and showing up for this talk. You are becoming the best advocate that you can for your loved one. And please stay engaged with IRSF. Take a look at our 2025 calendar and join us for future empowerment events. We wish you all well. Thanks for all that you're doing in October Rett Syndrome Awareness Month. If we share our children, the world listens and they pay attention and change can happen. So thank you very much. You all have a great day and we'll talk to you again soon. Bye-bye.